Hey guys, welcome. This is our Cytology for Allergic Cases lesson, and I'm excited because I really want you to use this diagnostic tool to improve your clinical outcomes for your cases. So let's get right into it. First off, I want to wish you all a happy new year. This is our January 2022 lesson, and I can't believe that 2021 happened. It was just one of those years where gosh, it was like, is this year ever going to end? And then it kind of just happened and now it's over. And anyway, here we are, new year. There's so much happening with the allergic dog that I'm so excited for you to be a part of. So again, I can't thank you enough for being a connection member. I really, really, really appreciate it and hope that this little program adds a little light to your day and also helps provide you with a cool resource for treating your allergic cases. So again, thank you so much. Happy New Year. And let's get right into it. So in this overview, I'm going to give you, or in this lesson, I'm going to give you a little bit of an understanding of microscopes, stain collection techniques, some examples and practical considerations. So basically, I just want to review how I do cytology. One of the things that we'll talk about in a future lesson is actually looking at cytology, and I'm going to try and bring in Kate Baker for that, who's my friend who has the Cytology Schoolhouse. So we'll actually do some real-time looking at tape preps and how to interpret them. I have some slides in this lesson that I'll provide for you so that you can see exactly when I'm saying coxibacteria or yeast. I think that we all are kind of at that level where you understand how to interpret some of the basics, but certainly learning a subjective scale, how to actually read the slide, especially tape preps when you're having to focus up and down, and all of that I think can be really difficult. So we will definitely bring in more about how to actually read our slides if that's something that is interesting to you. But in this lesson, I really just wanted to get information to you about what kind of microscope should I have? How do I actually stain my slides? And how do I actually set this all up and get the best sample? Because I think sampling is a huge concern for some people, and I want to make sure you guys are really on board with how to do your sampling. So why cytology? These are slides that one of the interns at Angel West collected. These are tape preps that, God love her, she stained, and she was trying, I don't know what she was thinking of evaluating with this clump of hair, but really this dog had a pyoderma, and she was doing her best to collect cytology. And I saw these in our little microscope area, which is usually used by me and the interns in our practice. And I looked at this and went right to her and was like, listen, Coley, you need some help. I'm going to help you with your slides. And so we did a little in-service and made sure that this is, in terms of tape preps, there are a few comments that I would make here about how she could make her samples a little bit better. First of all, using just a clump of hair, it's going to be super annoying. What exactly are you looking for on there? If we're going to look at hairs, we're probably going to just pull them out and use a trichogram. But even then, I mean, that's for something like a follicular dysplasia or something where you're not really going to look at a clump of hairs for something like a pyoderma, which is our most common reason for using cytology. And then the length of her tape, we'll talk about, it's making it so it's so hard to get good staining and have it adhere to the slide and all of that. So also my cat is back behind me, and she is I don't know what she's doing, but she's making noise. So anyway, I'm not going to stop her. I'm just going to let it happen. So if you hear something drop, that's my allergic cat looking in a box right now. Anyway, why cytology? Why are we doing this? Well, the whole thing is that it helps. It really helps make a diagnosis. So we want to make sure that we're not smelling our patients to make a diagnosis, that we're not looking at our patients to make a diagnosis. Sure, we're going to do all of those things as part of our general exam. Maybe not smelling. I tend to not be smells like yeast, and we can talk about that. But it definitely is something where cytology helps you actually make a diagnosis and visualize the problem. And it's pretty easy to do once you get the hang of it and once you have your system down so that it's a very efficient part of your day. And also you can train your technicians to do this. I have my technicians doing about 20% of my cytology, and I hope by the end of the year with more training training, they're doing 80 to 100% of it for me, with me just double checking, especially if the diagnosis is something that I really want to make sure that I have accurately, accurate like a pemphigus or something, where I'm using cytology in some cases to decide, do we want to make a biopsy for this patient? Do we want to pursue any other advanced techniques that we're really hinging on that cytology as a diagnostic tool. But for your general pyoderma and your malassezia dermatitis, it's going to absolutely help you say, this is a bacterial pyoderma, versus looking at the lesion, you're not always going to get it right. And then you could have a misdiagnosis and then create this whole chain of treatments for this patient that are inaccurate. And that's absolutely something that we want to avoid. I think I've said this in one of my other lessons, but we had this internist who was when I was an intern at Angel in Boston, Dr. Kirsten Johnson. She's an internist. She works in Western Massachusetts now. But we had this case where I was kind of just floundering my way through it, basically. And she said, we are in the business of making a diagnosis. And I heard those words and I let them sit with me. And I think of that all the time. When I need to know what it is, or when I'm not sure what my diagnosis is, I remember that my job is to make a diagnosis. And I tell the owner that if we don't have a diagnosis, I can't treat your pet accurately, and accurate treatment is going to be more efficient, it's going to be more targeted, and it's going to help your pet get better sooner. And that's what we're all here to do. And so making a diagnosis is hugely important, and cytology absolutely helps you do that. Track progress. So let's say we want to see this dog back in at 3 weeks. We're going to treat a pyoderma. We're going to have lesson upon lessons upon lessons, and probably a course about bacterial pyoderma and how to treat this appropriately. But in general, we want to treat a bacterial pyoderma for 2 weeks past clinical clearance. Now, that's for a pyoderma that we're treating systemically and not necessarily topically, which again, here's where there's just so much more. You just suddenly open up this little black hole of information. But to track progress, you want to get that pet back in here and you want to say, is your pyoderma resolved? And one of the ways that you can help yourself know that is by doing cytology and by checking and seeing if things are better, yes or no. And if things are not better, then you're going to need to pivot your treatment. You're going to need to consider a culture. You're going to want to add in baths, whatever the case may be. At the minimum, you're not going to want to stop treatment for your pyoderma unless it's something that's just not working, and you're going to then have a non-empirical selection of antibiotics because you say, oh, we're going to have to culture because you're not getting better. But definitely tracking progress with cytology really helps you to say, yes, this is better, or no, this is not better, versus just looking at the patient and then deciding. So I do think that having that as part of our track progress tool, especially for ear infections, is something that I do think really helps. Creating owner buy-in. Gosh, I love when I do slides and they're like, you're going to look at that right now? And I'm like, yep. Right here, right now. And sometimes I actually wish that I had a microscope in my exam room because I could just do it all in front of them, and then they would think I'm like some mad scientist, which they probably already do already. But I do think that it helps create buy-in. I don't ask for permission to do cytology. I just do it. And most people are totally fine with that. Now, if you're working in an area where you have a lot of financial constraints from your clients, you absolutely do need to ask them permission for anything that you're going to do. I get that. However, collecting cytology isn't something that you need to charge for. So I usually will, as I'm doing my exam, collect my cytology samples and then have them available to then go look at once I get a better sense of what is going on with this patient and with the owner as well. So that's something that you could do, is just have the samples ready to go, kind of do them as you do your exam, and then say, I would like to look at these slides so that I can make sure your dog gets the best treatment. The cost for this is $28, or the cost for this is $55, whatever it is that your clinic is charging, and then go ahead and get that buy-in from the owner. And I do think it really helps to elevate where you're at as a veterinarian who's saying, listen, my job is to make sure I give your dog the best possible care, and cytology is really going to help me do that. And then it generates revenue, there's no doubt. I'm someone who really tries, I put all my own charges in. And so I have to really remind myself that cytology has value and I need to charge for it, because sometimes I don't charge for it and I just like let it go, or I say, oh, you know, that's a recheck, so I'll just not charge for it. And I've really, for 2022, this is like one of my new missions, is just to make sure that I'm always charging for cytology, because it absolutely is a very important diagnostic test and something that we should be charging for and getting that value for. So, okay, cool, cytology is great, but like it's also hard, right? Because sometimes it's unclear. You look at your slides and you're like, I have no idea what's going on here. It's very subjective. Like what I say is a 4+ might be a 2+ to you, right? And my technicians, I have one who's very green and one who's a little bit more experienced, but they definitely differ in how they read their cytology from a subjective scale. And so training them up on that and giving them plenty of examples definitely takes time and is challenging. Owners decline this all the time because they don't see the true value, or they literally can't afford it. They're here because they just need to treat their dog and they don't have the extra $30 to spend on cytology. So that's definitely a challenge. And it takes time out of our day. We have to leave the exam room. We have to go read our slide. We have to collect the slides, stain the slides, all that it entails. So it's definitely, when you're running 15-minute appointments, it definitely is a challenge to add in cytology, and I absolutely get that. I do think that getting our technicians on board with doing cytology from some of the successful veterinarians that I've talked to. One of my friends, she runs 15-minute appointments, and I was like, how do you possibly do this? Because she said about 25 to 30% of her day is spent on, you know, skin and ear cases at minimum. And she said that her technicians are really significantly involved in cytology, and that they'll have it done by the time she gets out of the room. They'll do the history, the slides, they'll even do the collection. So if this is something you want your technicians to learn, absolutely have them watch this video. I think that it's very useful for everybody. All right, so overall, I do believe that cytology is a win. I do think it helps us make an appropriate diagnosis so that we can make an effective treatment plan for the patient. So it's definitely something that I strongly recommend that we all are doing in practice when we see our allergic cases, when there are lesions, and almost always the lesions are secondary infection. So that's basically the whole point, is that we're looking to document and determine the type of secondary infection so that we can treat that appropriately. So when you have a microscope, I think that it's really nice to just have your own microscope for your skin and ear cases. This allows you to just have your place where you're reading your slides, and you don't have to worry about your blood smears or urinalysis or whatever else that you're looking at under the microscope potentially be impacted by your oil immersion, whatever it is. Most of the time, this microscope that I have at work is something that we just use for skin and ear cases. But again, if you're a small clinic and you only have one microscope, like, it's not a big deal. Just make sure you're cleaning it. I think sometimes the bigger practices are worse because there's so many people using them and people just are sloppy. So designate someone to clean it. We have someone come in and clean our microscope, like, I don't know, twice a year or something along those lines. And it's really useful, but I don't clean my microscope every day. I probably am someone, you know, who does the least for my microscope. I just use my microscope and everything's fine. So don't overthink this, but definitely try to get a workhorse of a microscope. The one that I just showed you is, we'll talk about, but that in terms of like where that fit for us, you always want to think about like how much you want to spend. You basically need to use 10x and 100x oil immersion field. Teaching options, I sometimes do wish I had a camera and a second head, just because I could do a lot more for, you know, this type of lesson, to have really nice images and show people exactly what I'm looking at as I'm looking. You know, obviously if you're heavily involved in teaching, that might be a consideration for you. And then where are you going to put it? You know, does it fit in the spot? All of that is an ideal consideration for you when you're selecting a microscope. Oh, just back to that. This is the Nikon Eclipse E200, and I've been using this microscope now for years. This is actually my desk in California, in San Francisco, and when I moved to Angel in Boston, I asked them what microscope they had, and they had the exact same one. So I'm really happy with this. It is a sturdy microscope. It has great detail at oil immersion. It's just basically all that I need. So I think that this is a really good buy for most clinics. So there's that. Okay, stains. So we're all really just using diff quick stains, and that's absolutely appropriate for our skin and ear cases. So it's a commercially prepared Romanovsky stain. It is more efficient than using a Wright Giemsa stain, but it has a very similar outcome. And also we don't need to be doing gram stains on the majority of our cytology slides in clinic because we're often not trying to differentiate between gram-positive and gram-negative bacteria. There is some value to doing that, but that's definitely not something that I am doing on a daily basis and not something that I wanted to have in this lesson because I just don't think it's necessary to like go that deep when it comes to basic cytology. And the diff quick stain definitely highlights a lot of the cytoplasmic details. So basically what we're looking for is the cellular detail, the nuclear stranding, just highlighting cells. So basically what we're looking for is exactly what diff quick can give us. So this is the stain you're going to be using. And there are three components. We know there's a fixative, which I think a lot of people forget that the stain one is a fixative. So they're often worried about heat fixing or, how am I going to get my information to stay on the slide? So we do talk about that as we talk about how to stain each of the types of slides, but don't overthink it. The fixative is there for a reason, but it can be difficult because it can wash off some of your waxy stains like seborrheic detail or certainly ear slides. So it is important to know when and how to use your fixative. Obviously you have your eosin, which is going to be technically solution 1, which is your pink one, your eosinophilic stain. And then solution 2 is going to be your methylene blue. And that's going to obviously provide a lot of basophilic cellular detail for you. So these are the components of diff quick. So, okay, cool. We have a microscope. We have patients in front of us. Now, what do we do? So we basically have to know that there's a few things that we want to think about when we're thinking about getting cytology samples. So we want to make sure that we're picking the best lesions. So when we're looking at our patient, what type of lesions are present overall globally, and what is going to help us help this patient? So when I'm looking at a patient that has interdigital erythema, inguinal, axillary or glabrous region changes, maybe we have otitis externa, I'm probably thinking of using all three of our cytologic sampling methods in order to get the best whole picture for that patient. So I might do an impression smear of the axilla, I might do a tape prep of the interdigital space, and then obviously an ear swab. But you want to look at your patient globally and say, okay, all of these lesions look the same to me, so I'm just going to make one slide of, this spot. And that's fine, because if everything looks about the same, then you're probably going to pick a good spot as long as everything looks the same. But if you feel like, I'm not sure if maybe there could be yeast interdigitally, then feel free to just get a second sample so that you can say, yes, all of these samples are all yeast, or there's a lot of yeast in the pause and on the claw folds, but then he has a bacterial pyoderma on his belly. Those kinds of samples could be different and help you put a priority or rank list in terms of how you're going to treat that patient. So you look at your lesions globally as your patient as a whole, and then you decide, okay, which sampling methods am I going to use? And we'll talk about the three. And then how do you prepare your slide, right? So making sure that you're adequately preparing your slide so that you can actually read it is super important. So lesion selection. Basically, what do you want to sample and why do you want to sample it are the questions that you should be asking. So if you're looking at a collarette, a bacterial collarette, you're sampling it because you want to, one, document that that was caused by a bacterial infection and that that crusted spot is something that was generated by a bacterial pyoderma. And two, you want to then decide, do I need to or want to treat this animal systemically, or is this something that I might try to treat topically? Now, again, we're already getting like next step, next level outside of how to treat pyoderma, but that's basically the point. You're wondering, is this a superficial bacterial infection of the skin, or is this much more of a deep pyoderma where you have a lot of intracellular bacteria? What's going on here? How much inflammation is present? So you really are, again, the whole point of why you want to sample it is to get a sense globally of what's going on for your patient. So when we sample, we're looking primarily at primary lesions. So again, papules and pustules are going to be excellent lesions to sample because they are a representation of the primary problem that's happening. And you can absolutely generate a lot of useful information from doing, say, an impression smear of these papules. And the pustules are gorgeous places for you to collect a culture and to collect cytology from, because again, there are these preserved little pockets of neutrophilic inflammation, which really in most cases will have bacteria. And if they don't, then you might be looking at a pustular type lesion like a pemphigus. So again, it can really help separate out your differentials. Secondary lesions are going to be collarettes and crusts. These are also excellent lesions to sample. I think that I remember someone saying the answer is always in the crust, and I do think that that's true. There's a lot of information that you'll get from doing an impression smear of a crust. And so looking at these collarettes and then the crusted lesions that you can see surrounding them are excellent places to get a diagnostic sample from. Alopecia and lichenification is also very important to pay attention to. If you have hair loss with erythema and salivary staining, that's going to be a great spot to get a sample from. If you just have a non-inflammatory alopecia, you're probably not going to see a lot. So again, differentiating between the different types of alopecia is very important. But again, that's something that takes some time to figure out, okay, is this an inflamed sample? Obviously, you look at this dog's paws in this particular picture, and you can see that there's a lot of erythema. There's also some lichenification, which indicates to us that the dog has been self-traumatizing that area. So it's a real pruritic focus for that dog. And so doing a cytology of this area is really going to help you say, why are you so itchy here? Is it because there's just yeast everywhere, or is this just a spot where you're manifesting your allergy and there's a lot of inflammation? So again, these types of secondary lesions, the alopecia and the lichenification, are very useful. So you want to get representative sites that have primary or secondary lesions, and the purpose of doing it is to help you come up with a treatment plan. And that's the whole point of why you're doing cytology. So what are the collection techniques that we have available to us, and how do we get the best samples from your patient? Truly, there's three methods. We have the ear swab, the impression smear, and the tape impression. I use all of these every day. All right, so there's use and value for every single one of these types of sample methods for our patients with canine allergy. So the purpose, obviously, of an ear swab is to collect exudate and ear debris to evaluate that and determine, do you have inflammation? Do you have bacterial infection? Do you have malassezia? What's going on in the ear? Impression smears are going to collect cells from the skin surface. They're going to help you, again, make a diagnosis of bacterial pyoderma, malassezia dermatitis, whatever the case may be. Other diagnoses can come from an impression smear, like, again, I kind of hit on pemphigus, or certainly our T-cell lymphoma. In some cases, we can see a lot of lymphocytes in the skin. So your impression smear can tell you a lot. And then your tape impression, your tape impression is not going to be as pretty as an impression smear. And we talk about how to know when to do which one. But there's a lot of value in a tape impression, and it is something that I use in certain areas of the body or certain lesions that are present. And we'll talk about kind of how I like to use tape impressions for my cases. So ear samples first. So most of us, I think, are doing a good job with ear sampling. Typically, we're using our cotton tipped applicator to advance into the vertical canal and collect debris. Ideally, we should collect information or cytology sample from the junction between the vertical and the horizontal canal. There's a lot of information and studies about where to get the most diagnostic sample, but it can be very difficult because sometimes patients are incredibly resistant to getting a good deep sample. So just know that at different parts of the ear, you potentially will collect different levels of inflammation and bacterial or yeast infection. And so the junction between the vertical and horizontal canal really seems to be an ideal place if you can't get a sample from the actual horizontal canal. So I don't really stress about this too much. I try to get a sample right at that junction, kind of as the bend occurs, and I make sure that I'm pulling up on the pinna to retract the skin and that cartilage prominence that comes out, or if you hit that with your Q-tip or your otoscope, you're going to cause the dog some pain. So sampling the ear and how to do that is something that's important to make sure that you're, again, just pulling up on the pinna so that it spreads out the cartilage and reduces the size of that prominence, which can be painful if you touch that with a Q-tip or cotton-tipped applicator or your otoscope. But again, getting a swab from that section of the ear should be very useful to determine inflammation and to determine whether there's bacteria or not. And then here I have a picture of the rubber tube sampling technique, which one of my friends, Nellie Choi, she's a dermatologist now in Hong Kong, but her residence study looked at this method for sampling, and basically it's using a red rubber catheter that you advance into the ear, instill some saline, and then collect the cells from that area. And it also can be quite useful. In some cases, it was even less uncomfortable for dogs, so a good option for some dogs that have a lot of pain. And this is basically what you're doing. So you're advancing your Q-tip into the ear canal, and then you're going to turn and just kind of swab it around. It's not really that hard to just swab and get a collection of cells. And then you can see here that this is a video of me placing the exudate that I collected onto a slide. And what I do is place the cells from the left ear closest to the frost and then the right ear away from the frost. And so that is my standard. So I see some people doing like a line of left and right and then they have to label it. But to me, if you just put the left closest to the frost, that's easier to remember. So this would be a sample from the dog's right ear. And I like this method because I just kind of work back and forth, back and forth, back and forth to get the debris and the exudate to sit on the slide, and using some firm pressure. And again, I kind of roll that Q-tip onto the slide to get it to all adhere. And again, this is just highlighting the fact that I put the left closest to the frost and the right away from the frost. Now, you have your own system. You don't have to do mine, but this really works for me. And I like reading the two kind of segments versus the line, and definitely don't collect two slides for your ears. You can do this all in one. Okay, so staining your ear slides, I don't use fixative. So I will dip my slide into the eosin, and then I will dip my slide into methylene blue, like 15, 30 seconds. And I rinse my slide gently. It takes a while to turn my water on. And then I'm going to use the edge of the paper towel to rinse off the bottom of the slide, and then the bibulous paper to dry my slide. And that's it. And you can see that the slide there is stained. So if you have a severely exudative slide for your ears, then you can do heat fixing to help get the cells to stay onto your slide. But if you have heavy exudate, there's really no way around it. It's going to sometimes come off on the bibulous paper. So sometimes just not using that and letting it air dry is what I'll do. But for a cytology like the one I collected, where it's pretty thin and it just is a covering on the slide, doesn't have a lot of like pus chunks and cerumen chunks, then that's something I feel like this method works very well for. When you have heavily exudative or very ceruminous ear discharge, leaving it in each sample to just heavily stain it and kind of get through that exudate is totally fine. So you could leave it in the eosin for a minute and leave it in the methylene blue for a minute. I think there was a post recently on one of our Facebook groups that was talking about like, put it in one of the slides and go to the bathroom, you know. So it's really, you're not going to ruin your slide if you overstain it. It's not possible. So it's just something where, well, I suppose it is technically possible, but it's not going to be something that we do in day to day, especially when we're moving through our cases. So don't worry too much about that. So again, just to review, I use my two stains, my two colored stains, not the fixative. I'll sometimes do heat fixation if it's a very exudative sample, but for the most part, I'm doing solution 1 and solution 2, and then reading my slide. And how I dry my slide is with the bibulous paper. I love that stuff. It helps speed me up, and it's something that, yes, it will, if your ear exudate is not tightly adhered because you didn't fix it to the slide, then you will take some off, but that will not happen if you have a slide that's a very thin sample like the one that I showed you in the video. So we've talked about this gentle rinsing. I'm not sure if you guys have a special area. For, you know, the concern of just like environmental sensitivity and making sure that we're disposing of our slides correctly, the gentle rinsing is something that we do. But having, I remember at one of the clinics I was working at, they wanted us to put the slide rinse into like a little bucket, basically, that was then disposed of separately and not down the drain. So that's something that you should look into your own local regulations for, because these stains aren't something that are fish friendly. And then bibulous paper definitely is very useful. If you're not using it, you should be. And heat fixation is not always necessary, but it is sometimes useful for your thick exudates. You're going to start at your 4x and get your area of interest and then go up to 100x. I don't mess around with the others. So here's what we can find. This is a great sample of the yeast otitis. So there's going to be plenty of yeast here. And again, like, what would I call this? Probably 2+ yeast, maybe 3+, depending on my mood. But really what matters is that I call it something and then my eye kind of sees it a different way the next time, and your subjective scale is your subjective scale. We're documenting the presence of yeast. This is more than 5 per high-powered field, and so this is an abnormal amount of yeast in an ear. We don't see any inflammation. I don't see any neutrophils on this slide. So again, these are corneocytes. So you can see they're anucleate keratinocytes, which are normal in the ear. And then here again is another example of yeast. There's some hair here. And then, gosh, look at these rod-shaped bacteria, long kind of strips. So these could also be streptococcus. So we have different, if we have some neutrophils here, I have no idea the type of bacteria. You should not be guessing on cytology. You should just be documenting that these are not true cocci, that these are rod-shaped bacteria, and or that they're forming chains. That's very useful to document. And then we do see some ground substance with the kind of purple debris that's there. And then this is an example. This is a neutrophil here, a neutrophil here, a neutrophil here. So it is important to document the presence of inflammation in your cell. This is a mixed infection, so you can see that there's some nuclear streaming, proteinaceous streaming, nuclear streaming. This is all from neutrophils. You can see that there's yeast, so here's a yeast, here's a yeast, 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 and then you have a pleomorphic population of bacteria. So this is important to document that there are some cocci, there's some rod-shaped bacteria, there's plump rods, you know, however you want to describe it, but we shouldn't be saying, oh, these are, you know, Pseudomonas just by looking at it. We should just be documenting that this is a mixed pleomorphic population of bacteria with yeast. In the when to culture, this might be one that you want to consider culturing because it would be useful to know the types of bacteria that are present here. But again, that's a whole other lesson. So rod-shaped bacteria again, and tons and tons and tons of neutrophils and proteinaceous streaming. So this would be an ear that I would be concerned about. When you have predominant rod-shaped bacteria, you do worry about something like a Pseudomonas. Pseudomonas can be very difficult to clear because of the biofilm formation and the erosion and ulceration of the ear canal that it can cause. And so it is something you want to pay attention to. But again, there's an entire course on its way just about ears. So stay tuned for a lot more there. Your goal is to determine the infection type. So when I do ear cytology, I'm really just asking myself, is this bacteria, is this yeast, or is this both? And then I also want to determine the level of inflammation. So are there neutrophils present? Are there some macrophages? Is there any other type of cell here that's indicating to me that there is a lot of inflammation present? Because the presence of inflammation is going to change your general direction of how to treat your ears, because again, you want to make sure that you're addressing that inflammation as well as the infection. And then remember, it is a subjective scale. So 0 to 4 plus, or too numerous to count, is generally what I'm using so that you can compare to last time and evaluate your treatment efficacy. But again, it's a subjective scale and it's something that you come up with. There are some that are available, but I don't, like, to me, I've just developed kind of my own system. And I think if you do enough cytology, you can come up with that. If you want me to get the 0 to 4 plus or too numerous to count scale for you guys, I definitely can. But again, just remember that it's not something that you're going to get an A plus on the test. If you write a 1 plus or a 2 plus and that's wrong or right, it's subjective and totally for you to use to evaluate treatment efficacy. So not something that I want you to overthink or worry about. Okay, so we covered ears. Let's move to impression smears. The impression smear is something I use all the time. It's the best. It's very useful. Ideal lesions are going to be your papules and pustules, crusting or scale, and then seborrheic changes or lichenification for sure. And this is how you do it. So you take your slide, you use the leading edge of the slide to rub on the skin, and then you kind of give it a good press. So leading edge, press. And the benefit to doing it this way is that you're going to be able to sample any type of lesion. So you can do this on a dry lesion, on a moist lesion. It does not matter. This dog had M. canis. Yikes. So these are all in bacterial pyoderma, but that was not a problem. So this was a nightmare case in San Francisco. Immunocompromised dog with generalized M. canis. Anywho. So impression smear. Now you get your impression smear sample. How are you going to stain it? I use my little clothespins. Obviously this needs a fixative. So it's going to be something where you jangle it in the fixative for a little bit, 15 seconds or so, move it around in solution 1, get your eosinophilic stain, and then move it into your methylene blue, solution 2. Long enough, and then you're going to rinse it. Sometimes people notice that oily film that covers in their methylene blue, that's actually the eosin. So you can rinse them off between samples. If you're doing the eosin, then you do a rinse and then you go to methylene blue, that's fine. But it doesn't impact your diagnostic quality. So that's how you stain your slide. This actually was a slide from a normal dog. And so there's not a lot of uptake on there because there really wasn't a lot going on. So when you have a normal skin impression that you're going to do on an inflamed collarette or something, you're going to pick up more cells. And that's, you're obviously going to see that on your slide. So again, using all 3 components of your Diff Quick staining for an impression smear. Other tips, I don't heat fix my impression smears unless there's just a tremendous amount of exudate. So if I had, a really like a nodule that had a lot of exudate from it where I'm doing an impression smear of that, it's very thick. Sometimes it's useful to do heat fixation on that type of lesion. Gentle rinsing is important. And then again, I use my bibulous paper just to get me to go through faster and not have to wait for them to air dry. 4X and then oil immersion is basically what you're looking at again. And then here you can see these are some examples. This is a ton of neutrophilic streaming, which is very important to document. And then you also want to identify the predominant type of infection. And in this case, it's a staphylococcal infection. Now, this is a cool slide because you can see that this is a neutrophil and there's a lot of bacteria present within the neutrophil. So intracellular cocci tells you that there's a lot of inflammation going on here, and that now you have intracellular bacteria, which is really going to tell you that it's more not overgrowth than an infection. So there's actually infection happening that the body is responding to, and so it does kind of put the severity up a level versus some bacterial overgrowth, which is like a downgraded version of that. So This is a weird one. So this is again an example of an impression smear that was done, and these are all lymphocytes, and I don't see a single bacteria here. So if you remember back to some of our other conversations that we've had about diagnosing atopic dermatitis, you remember that we talked about your scaling erythroderma. Well, this is a great example of a scaling erythroderma where you can see this dog just has flakes of skin that are coming off, and then you have your scale that's present, and then we did an impression smear of these lesions, and it's all lymphocytes. So our concern for epitheliotrophic lymphoma is very high. Oh, look, a Demodex. So sometimes you find demodicosis on your impression smears as well. It's kind of like an added bonus. But again, look at just how much inflammation is present. You really need to make sure you have a plan for inflammation when you see it. And that's something that I talk a lot about in my course because it's, I think, one of the hallmark features of our treatment for atopic dermatitis is management of inflammation. So impression smear goals. You want to decide, is this a bacterial infection, is this yeast infection, or is it a complicated infection where we actually have both? We also want to determine the level of inflammation because you need to be able to treat that adequately. And then remember, it is subjective. So this is your scale and your scale alone, and it doesn't matter if someone else says, oh, this is a 3+ or this is a 2+. To me, it's still there. So it's either all or nothing, right? Like you're either seeing no bacteria and this patient has resolved its bacterial infection, or you're still seeing bacteria or yeast. And between, splitting the hairs between whether it was a 3+ when my colleague saw the dog and now it's a 2+ is not really like that important. If we're really getting into that level of specificity, then maybe as a clinic, you guys can decide, okay, do we have some sort of yardstick that we're going to use that anything over a 2+ is going to get systemic treatment, anything under is going to get topical. But even with my own practice, I don't do that. There are some cases where baths seem like a great option, and other cases where it's probably a better idea to treat systemically. And again, that's going to depend on the depth of the lesion, how severe the lesion is, how severely the dog is affected by everything, and what else I'm adding to that dog's plate when it comes to medication. So that isn't what we're talking about here. We're just talking about samples. But again, it's so hard not to kind of get into those little topics. But it's just a matter of using your impression smear to make sure you're actually making a diagnosis appropriately for the type of lesion that it is, and then deciding how much inflammation is present because it might change your treatment plan for inflammation. Okay, so we covered impression smear. Woohoo, we're done. Now we're on to tapes. So I love tape impressions. I think they're very useful. The regions that I like to sample with tapes are interdigital spaces, glabrous regions, which are going to be your inguinal area and your axilla, and then anything that has a lot of seborrheic change or lichenification. Seborrheic change is basically like getting an ear swab of the skin, right? Because you're going to have all this seborrhea, you're going to have all this kind of waxy debris that's coming from the skin. And so sometimes the tape can really help neutralize that, and it makes it a little easier to look at those slides than having to worry about them washing off with the fixative. So if you got a heavily seborrheic impression smear, I would not do step 1 with the fixative. I would just treat it like an ear slide. But as you'll see with the staining for tape preps, you don't have to do that because there's a special way that you stain them. So ideal lesions, basically anything that is interdigital, I think it's so much easier to get tape preps of interdigital spaces than it is to get an impression smear in those areas. Supplies that you need are going to be obviously slides. This is the crystal tape that we use, so you want to make sure that it's the clear tape, not the frosted tape. And the stain, obviously, that's it. Pretty basic. And this is how you get an appropriate sample. So you're going to take your tape and you're going to press on the area of interest, moving the hairs out of the way, and you're going to do that firmly. So you want to aggressively press the area several times. So I think at least 5 times, 1, 2, 3, 4, 5, and then I'm kind of going back, moving the hairs out, getting a little bit more up there. Okay, so now I have my sample. And when I'm staining my impressions, I get a syringe filled with methylene blue. I place the needle under the stain and I flood the area. Take a paper towel, the thicker the better, else you'll get your fingers stained. and I press, and then bada bing, your slide is stained. So never do fixative on a tape. It'll just take off the tape. And then you're not going to get any value from using eosin. So really what we care about is staining cellular components with our basophilic stain, and that is going to be best accomplished with the methylene blue. So I'll show you guys that again. So suck up some stain. The needle goes right under the tape. Flood it. You can let it sit there if you want, but I'm usually moving through this real quick. Press it, done. All right, and that should get the information that you need from your tape preps. So again, we're just using solution 2 or your methylene blue. Do not rinse, do not use fixative, your tape length. Okay, so this is one of the issues here, that the tape length was just insane. So tape length should really just be about 3/4 of the slide. So you want to make it so that it starts here and then just kind of ends here. If you have this long dangly, it's just going to be something that gets in your way. And then 4x to get your area of interest, and then use your 100x oil immersion to evaluate your cellular characteristics. And I think that one of the biggest challenges with tapes is that you do have to use your fine focus to go scan up and down. So you will have layers of information, especially if you have a seborrheic sample like a interdigital space or an armpit area where you're going to have a lot of potential seborrhea. And so you do want to make sure that you're evaluating on all of the planes of that impression. And so you need to use your fine focus for that. And you determine your infection type. You're again just looking to say, is this yeast, bacteria, or both? And then determining if there's inflammation. It can be pretty tricky to, like when it comes to slide noise, I think looking at inflammation is really, really hard on tape preps. And so if I see neutrophils, great, but pretty much when I'm doing a tape prep, I'm asking the question, is there yeast? Like that's pretty much my question for tape. So I really just want to sample, again, interdigital spaces are like my go-to for tape preps. And so I'm sampling those areas, and also claw folds. Those are great spots to get tape. And then again, like I mentioned, your glabrous regions. But the question I have is pretty much going to be, is there yeast here? Yes or no? Because I do think yeast exfoliates really nicely on tape preps in these spots. And then if you don't see any yeast, sometimes I will actually go back and make an impression smear just to see if there's bacteria present, especially if I have a lot of primary lesions, like, a lot of erythema or something where the dog's heavily lichenified the area. Sometimes you need a backup impression. But yes, you're going to have slide noise, and you have to learn how to ignore that basically by setting your eyes to look for things that are similar. So slide noise is going to be stuff that just doesn't look the same as all the rest, where when you have bacteria, they're going to be, in terms of their size, they're all going to be the same size. So if you think you saw one single cocci, do you see another one? Are there 12 more that look identical to that one, or was that just a piece of debris? And so that's how I look for or ignore slide noise, is just basically by training my eye to look for things that look the same. And I ignore, I just try to get a blanket image and pick out the things that to me all look the same. And like in this slide, I would say there's yeast. I wouldn't even attempt to decide if there's bacteria here. I would go back if I thought maybe there could be a bacterial pyoderma. I might go back and do an impression smear. But oftentimes what I'm doing is prioritizing the type of infection. So if this dog's super pruritic, I'm going to start them, let's say, on, Apoquel, and this is a tape prep and I found a ton of yeast. I probably would treat for yeast and then make sure that the dog is doing better. And if there's a bacterial pyoderma, well, you're also going to always be adding in something for the skin barrier, because you're treating, your skin barrier and your inflammation in all of your cases. And so that's something that I would hope would be improved by using some sort of topical. And so again, the predominant type of infection to me on this slide would be yeast, and I wouldn't hunt for any more for bacteria because it's just not very prominent. So again, these are just like little kernels, and I can expand on all of this so much more. Maybe we could talk about this at our Zoom call this month, because again, this is, I think, the biggest challenge is interpreting our slides, but I just really wanted to make sure you guys knew how to collect your slides. So air bubbles are super annoying. Staining issues, now you know exactly how to stain them. So again, we just reviewed this. So scan a few times, make sure you're getting a lot of different places that you're sampling on your tape prep. I'm looking for predominant infection type, and then don't expect to see inflammation well, and sometimes you do need to get a backup impression smear. And again, when you're doing cytology, you really want to remember your goals. You're attempting to make a diagnosis, you want to track progress, you want the owner to be right there with you, and you're hoping to generate a little bit of revenue. These are pretty low-hanging fruit goals that we have, but I do think cytology is very useful for all of us in the clinic. I can't wait to hear what questions you have after listening to this. I hope that this was helpful. I can provide anything else that you need to make cytology successful for you, for your technicians in your practice. I'm happy to do any sort of like live, I'll stain stuff, whatever it is that you guys need to really make this something that works for you in your clinic, and helping you with your patients is definitely my goal here. So again, hope this was helpful. Let me know what questions you have, and I'm going to sign off for now. Thanks, guys.